Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see, are based in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present in this channel. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of these series of talks, which span over 6 videos, is the echocardiographic analysis of left ventricular diastolic function and dysfunction as seen in the real world. It is a fast, synthetic, basic approach to this topic, which is quite large, and I will provide further on more detailed, a large video with a more in-depth approach. Now, these talks assume that you have a basic understanding on how to perform pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use tissue Doppler, myocardial tissue Doppler. And it is also assumed that you know how to perform basic echocardiographic measurements. However, you will find in the website echobyweb.com, I've just mentioned it, a large quantity of material, educational materials to address these topics. This is an outline of the 6 talks on the analysis, the echocardiographic analysis of left ventricular diastolic function and dysfunction. So the first talk we will look at definitions of diastolic function, diastology, and its clinical utility, the utility of the echocardiographic analysis, and then there will be a basic presentation of the physiopathology of left ventricular diastolic function. In the second video, we will look at how to estimate left ventricular filling pressures with echocardiography, and we will look at the current recommendations, the 2016 and 2025 latest recommendations on the analysis, the echocardiographic analysis of LV diastolic function. The third video, we will see a complementary analysis which is based on the assessment with echocardiography of pulmonary diastolic pressure, and then we will see how to estimate LV relaxation and compliance with echocardiography. The fourth video will all be about how to grade with echocardiography diastolic dysfunctions. The fifth video will be on how to report with echocardiography diastolic function and dysfunction, and we will see a series of clinical cases. In the sixth video, we will address the problem of sinus tachycardia and how to solve it, so to perform the analysis also with a fast heart rate. Then we will look on how and why to perform the Valsalva Maneuver. We will look at specific patient populations and see the conclusions. This is video number 6, from the analysis of tachycardia to the conclusions. In this other clinical case, we have a 68-year-old female chronic ischemic heart disease with mild to moderate septal hypertrophy. But blood pressure is well controlled, 140 on 80. We have normal end diastole, indexed end diastole biplane and diastolic volume, it's 49, normal ejection fraction. And there is upper normal, mildly dilated left atrial volume index here, 36 milliliters per square meter. The mitral flow profile, this is the 2D exam you can see here. Okay. The mitral flow profile is normal for the 68-year-old lady. The E wave is 87, the A wave is 113 centimeters per second, so the E on A wave is 0.77, and deceleration time is normally 230 milliseconds. Let's look at tissue Doppler, which shows an average E prime of 3.5, so a severe prolongation of left ventricular relaxation, and it follows that the E on E prime, because of the E wave, which is 87, is 25, so this suggests increased filling pressures. However, pulmonary systolic pressure is normal. You can see here tricuspid regurgitation, peak velocity 1.7, and pulmonary diastolic pressure is the end diastolic gradient is 2.5 millimeters of mercury. There is a normal inferior vena cava collapse with inspiration, which means that pulmonary diastolic pressure is less than 9, which suggests that wedge pressure is normal. And this is consistent with the transmitral flow profile here, which is consistent with normal filling pressures, not with high filling pressures because of the parameters. Now, if we go to the algorithm, the 2016 algorithm of the American European recommendations, you will see that it will give you as an output normal filling pressures less than 15 and a diastolic function class of 1, impaired relaxation. If we look at the alternative algorithm that I have suggested you in the previous videos, it gives you normal filling pressures. But if we go to the most recent algorithm of the American Society of Echocardiography, the 2025 new algorithm, it will give you a grade 2 pseudonormal diastolic function class with high filling pressures. And why is this? This is because this new algorithm gives priority to E on E prime, which in our case is clearly misleading. And why is this E on E prime misleading? Because we have a substantially normal E wave, which is a bit high for impaired relaxation, and a very low 3.5 denominator of E on E prime, such that the ratio is increased. But this is definitely misleading in this clinical scenario here. Let's move on to another clinical case. We have a 74-year-old gentleman which is admitted in the emergency department with dyspnea on mild exertion. He had a history of hypertension, uncontrolled with combination therapy. Blood pressure at admissions was 180 on 90 and was in sinus rhythm, 58 beats per minute, as you can see here. Echocardiography showed mild to moderate left ventricular dilatation, 90 millimeters per square meter, with the mild reduction of ejection fraction, 50.5, normal segmental wall motion, moderate left atrial dilatation, 45 milliliters per square meter, and severe pulmonary hypertension, 60 millimeters of mercury. The analysis of pulmonary regurgitation showed an end diastolic gradient of 11, so it pointed to an increased pulmonary diastolic pressure of 17 with a normal inferior vena cava collapse and estimated right atrial pressure. So here wedge pressure was estimated to be increased. So how do we explain these conflicting findings? Because we have on this side here increased filling pressures, suggested filling pressures, and on this side here we have a apparently grade 1 diastolic dysfunction, impaired relaxation mitral flow pattern with an E wave here of less than 80, an A wave of about 100, and an EA ratio of less than 1. So this transmeatal Philip pattern suggests that we have prolonged relaxation but normal compliance and normal left ventricular filling pressures. Crucial interpretative help comes from the echocardiographic examination, which was performed as an outpatient 6 months earlier here in B, which was retrieved from the digital database of the institution. So in B, down here, we see a very typical prolonged relaxation transmeatal flow pattern, grade 1. We have a low E wave, 38 centimeters per second, with a prolonged deceleration time, 310, an A wave which is 80 centimeters per second, and an EA ratio of 0.48. So if 6 months earlier we had a grade 1 diastolic dysfunction, which is the grade of diastolic dysfunction that we are observing now in the emergency department. Grade 1, grade 1B, grade 2. Let's compare the echocardiographic measurements performed in the 2 exams, so 6 months earlier on the left and the emergency department now on the right. New York Heart Association is class 1, 6 months earlier he was asymptomatic and now he is dyspnoic. So blood pressure, which is the afterload of the left ventricle, is mostly unchanged. The end diastolic volume index 6 months earlier was 40, was normal, and now it's more than doubled. Ejection fraction went from 58 to 51, so significantly decreased, and we must remember that ejection fraction, the changes should always be interpreted in the light of the determinants, which are heart rate, preload and afterload. So here heart rate is similar, afterload is similar, but we have a marked increase in preload. So this suggests that since preload is increased, afterload doesn't change, ejection fraction goes down. So this is probably a reduction in left ventricular contractility that we are seeing here 6 months earlier and now. So we have in the background here a progressive anatomical and functional remodeling in chronic hypertensive heart disease. Let's look now at the diastolic parameters. The E wave has doubled, from 38 shoots up to 67. Deceleration time is halved, goes from 310 to 190. And the A wave has slightly increased with an EA ratio which has increased. So here the EA ratio hasn't changed much, and this is the confounding factor because all the other parameters have significantly changed, and the EA ratio tricks us into considering the pattern that we see now in DR as a classical prolonged relaxation pattern. Actually, the underlying prolonged relaxation pattern is now masked by a significant increase in atrial pressure, as suggested by the great increase in the E wave, the decrease in the deceleration rate, and most importantly, by the increase in the estimated wedge pressure by the pulmonary regurgitation analysis. And this is confirmed by the significant increase in pulmonary systolic pressure, as you see here, from 29 it shoots up to 60 millimeters of mercury. So which is the grade of diastolic dysfunction here? We have established that filling pressures are increased, and the grade here is now 1B, as I have explained you in one of the previous videos, because it is not grade 2 because the EA ratio is 0.69, and to be grade 2 it should be, the EA ratio should be between 0.8 and 2. You may ask, where is tissue Doppler of the mitral annulus here? Well, we don't have it because these exams are quite old, before tissue Doppler was routinely used, so we don't have it. In this case, the E prime would have been quite low in both exams, so not very helpful in determining the filling pressures and the grade of diastolic dysfunction. So what do we learn from these examples? First, appearances can be deceiving and the devil is in the details. Never rely on a single diastolic parameter. Always use the flowcharts and consider the whole picture. It is like a puzzle and all the pieces must fit in the frame of the puzzle. But second, non-invasive estimation of wedge pressure using pulmonary regurgitation is very rewarding in my experience. So I would strongly consider using this parameter always in diastology. And last but not least, mandatory digital storage of exam can be life-saving, as you saw in this last case here. Well, in a certain number of cases, especially in the emergency department, the patient may be in sinus tachycardia, and the increased heart rate may confound us because the flow pattern will show a summation pattern, as you can see in A here, a single wave. This means so that the E and A wave are superimposed because LV relaxation, because atrial contraction occurs on left ventricular relaxation when the heart rate is above 90 or 100. In this case, it is essential to slow the heart rate, and we can do that very well with a classic carotid sinus massage. This allows us to reveal the underlying impaired relaxation physiology, in this case, as in B, and this avoids confusing the summation profile here with a single A wave or a single E wave, both of which instances can occur in real life. Now, it is very important to have the EKG trace here, as always. We should always have the tracing, EKG tracing, when we do echocardiography. It allows us to reveal that the summation wave here begins before the P wave. Thus, this initial upsloping here is not an A wave, it's the beginning of the E wave. And you can see a little notch here on the upsloping. This little notch here is the E wave. E wave here, E wave here. And then you have the EKG P wave, and the rest of the wave is in fact an A wave. By slowing the heart rate, the A wave moves away from the E wave, and we can see both of them. The simultaneous recording of the pulmonary venous flow here in C is also very helpful. It allows us to see that left atrial physiology is normal because we have, and so filling pressures are normal because we have a dominant systolic wave which begins at the QRS here. And then we have a much smaller D wave during diastole here. And we have the same situation here using tissue Doppler, septal and lateral. Okay, baseline in A with the sinus carotid massage in B. So in the baseline, the white dot shows the summation wave here, this one. And with slowing of heart rate, this wave, you can see, becomes a biphasic wave with an E prime and an A prime, septal. And here on lateral, the same thing. This is the summation wave. And then we have an E prime and an A prime during slowing of heart rate. But then you could ask me, what about this wave here pointed with the arrow here, the white arrow here and the white arrow here, so on septum and lateral? Isn't this a wave? So if this is a wave, myocardial wave, then we would have an E prime here, a normal high peaking 10 prime here, and a small A wave here, and the same on the lateral annulus, a high E prime here and a small A prime here. That is not the case because, and here is essential, the EKG is essential. You see the EKG here and you see that this small wave occurs inside the EKG or afterwards. So this is not an A wave, this is an isovolumic wave. Again, the EKG is essential to distinguish these pitfalls that can occur quite often. Let's talk now about the Valsalva Maneuver, which is relatively simple to perform even during a routine examination. It's a fast maneuver in 4 phases, and it's very, very useful in diastology. There are 4 phases. We're interested mainly in the phase 2 stable phase. The early phase 2, there is an increase in intrathoracic pressure, which reduces systemic venous return. The reduction in venous return can vary greatly from patient to patient and how the maneuver is performed. During the stable phase, which is longer, here where we can do the echocardiographic evaluation because it's stable here. The reduction in venous return produces a drop in cardiac output and a reduction in left ventricular volume and in left atrial volume. There is also a reflex tachycardia. In phases 3 or 4, there is a rebound with the re-establishment of the normal intrathoracic pressure. Now, the Valsalva Maneuver reduces dramatically and very fast left ventricular preload. So why would we want to perform an echocardiogram during an acute reduction of preload? Well, because we know that the mitral flow profile, the E wave, the A wave, deceleration, these parameters, they change with varying preload and filling pressures. So the grade 2, 3 patterns, the high peaking E wave and increased EA ratio are maintained by increased filling pressures. If we reduce the filling pressures and the preload in patients which have increased baseline filling pressures and grade 2 or 3 diastolic dysfunction through an acute reduction in preload with Valsalva Maneuver, then the pattern will change from a restrictive or pseudonormal one to an impaired relaxation one. And this maneuver, this going back from stage 3 and 2 to stage 1, will confirm us that we were indeed looking at a patient with high filling pressures. But if the patient that we are observing with our echocardiographic examination has a stage 1 impaired relaxation or a normal pattern, the Valsalva Maneuver, the reduction in preload, the Valsalva Maneuver will reduce both the E and the A wave symmetrically. Whereas if we have a stage 2 and stage 3 or stage 3, the reduction in preload will reduce mainly the E wave you will transition from a high E wave ratio to a less than 1 EA ratio. Whereas in a normal diastolic baseline function, the EA ratio at the end of the Valsalva Maneuver will be substantially unchanged. So the Valsalva Maneuver, the aim of the Valsalva Maneuver is to identify patients with stage 2 and stage 3 diastolic dysfunction. And the diastology and the maneuver is indeed inside the recommendations. It was since the 90s, in fact. It's a second line assessment. And here we have 2 examples of 2 patients. Up here we have an ischemic dilative cardiomyopathy with normal filling pressures here. And down here below we have ischemic dilative cardiomyopathy but with increased filling pressures. In the patients with normal filling pressures, you see that the EA ratio from baseline to the end of the Valsalva Maneuver does not change. But here, in this patient with a very high EA ratio in the baseline, we see here in real time the Valsalva Maneuver. You see that it doesn't take much, and here you start beginning to see a reduction of the E wave, an increase of the A wave, increase in deceleration time. Look, the E wave is plummeting, and now we have an inversion of the EA ratio at the end of the Valsalva Maneuver. This confirms that the patient down here had indeed high filling pressures with a grade 3 diastolic dysfunction class. And finally, we have specific patient populations which are mentioned in the recommendations, both the 2016 and the 2025. These special populations are patients with atrial fibrillation, which are quite common, sinus tachycardia, well, we just saw how to deal with that, hypertrophic cardiomyopathy, restrictive cardiomyopathy, pulmonary hypertension. In these patients, the algorithm may be quite inaccurate because there are specific problems. For example, in atrial fibrillation, you don't have an A wave, and peak E wave and deceleration time can change from beat to beat, and single parameters, and in general, the algorithm can be inaccurate in hypertrophic cardiomyopathy. So we can see that in patients with atrial fibrillation, you could use a cutoff of 160 milliseconds for the E wave deceleration time in patients with reduced ejection fraction, which means depressed ejection fraction, sorry. Or you could use a isovolumic relaxation time of less than 65 milliseconds. I didn't show you how to measure isovolumic relaxation time in this series of videos, but I will post in the future a longer assessment of diastolic function with how to use also these second line parameters. And then we have the E on E prime, which they suggest to use the septal on 1 without a lateral above 11, and a peak tricuspid agitation velocity of more than 2.8. And in hypertrophic cardiomyopathy, for example, an average E on E prime more than 14, and then you could use the difference in the duration of the reverse and antegrade A wave, a difference of more than 30 milliseconds would suggest high filling pressures, as also a high tricuspid agitation velocity of more than 2.8, and any large left atrial volume index. Here we also have patients, special patients are considered also those with mitral stenosis, mitral agitation, calcifications of the mitral annulus, in which you cannot use the myocardial velocities on the post-operative tissue Doppler imaging. And then you have patients with left ventricular assist device and cardiac transplant patients. And these are the conclusions of this talk. So in diastology, the analysis is necessarily multiparametric. You cannot use a single parameter. It is advisable to become familiar with an algorithm. Use it in normal subjects, in patients with mild reduction of function, in patients with severe impairment of function. The method is accurate and reproducible, but necessarily only after a learning curve. And always relate your findings to the clinical status of your patient. So this, in summary, is what we have talked about in these 6 videos. The first video was about the definitions of diastology and its clinical utility, and then physiopathology, the minimum basic physiopathology that you need to know to perform diastology. The second video, we looked at how to estimate filling pressures, and we looked at the current algorithm, the current recommendations 2016 and 2025. In the third video, we looked at the utility of measuring pulmonary diastolic pressure as a parallel way with the standard algorithm. We looked also at how to estimate left ventricular relaxation and left ventricular compliance with echocardiography. In the fourth video, we looked at how to grade with echocardiography diastolic dysfunction. The fifth video was about reporting diastolic function dysfunction, and we saw some clinical cases. Whereas in the sixth video, we looked at other clinical cases, how to deal with sinus tachycardia, how to use the Valsalva Maneuver, the parameters that are necessary in specific patient populations, and then our conclusions. So I would also like to remind you in the end about the website echobyweb.com that you can find on the internet, where you will find most of these materials, sometimes more in depth. And especially you will find calculations, methodology, and the Excel spreadsheets of which I showed you before, which you can use to evaluate, to play with the recommendations. And so again, this is Echo by Web YouTube channel, and see you for the next talk.